Good morning, one and all present here. I, Dr. Sushmita, postgraduate trainee of Department of Oral Medicine and Radiology, welcome you all to our 7th webinar of the Mega Webinar Series. Now, I would request Dr. Satyaranjan Mishra, sir, to welcome our speaker, Dr. Ravikiran Ongole, sir.
Good morning, everybody. A very pleasant good morning to one and all from all parts of the country. This is our 7th webinar. Respected teachers, senior colleagues, especially Omarji sir for attending all our webinars. We are really thankful. You are an inspiration, sir. So it gives me great pleasure to invite everyone for this webinar. And today's topic is on orofacial pain. Now, before going to the topic, I might tell you that as a postgraduate in 2007, we had this small clinical manual of oral medicine and radiology by Ravikiran sir. So I read his book from my PG days. So it's a great opportunity to hear sir as a speaker today. And hosting sir for a lecture is definitely a fortunate experience. Sir has agreed for that, and not keeping the audience away from the lecture, I'll tell Dr. Sushmita to formally introduce sir. Thank you.
Thank you, sir. Dr. Ravikiran Ongole, sir, has earned his master's degree in the specialty of oral medicine and radiology from Manipal University in the year 2002. Ever since, he has been pursuing his passion for teaching and was a recipient of Good Teacher Award in 2012. He has authored 2 books in oral medicine and radiology and is on the advisory board for the first South Asia edition of Textbook of Oral Radiology edited by White and Farrow. Dr. Ravikiran sir has been invited to speak at various CMEs and international conferences and was the symposium speaker at International Association of Dental Research and American Association of Dental Research meeting at Boston in 2015. Also, he was a keynote speaker at Royal College of Surgeons in Ireland 2016. He is actively involved in funded international collaborative research projects dealing with the prevention, detection, and medical management of oral precancers. At the university, he is the staff mentor for the Student Research Forum, member of institution's Scientific and Ethics Committee, and also the coordinator for the Innovation Center. He is the editor-in-chief of Manipal Journal of Dental Sciences and is currently serving as professor and head and PhD guide at Manipal College of Dental Sciences, Mangalore. So please join me in welcoming Dr. Ravikiran Ongole, sir. Over to you, sir.
Good morning, everyone. Hope I'm audible.
Yes, sir.
Okay, so at the outset, Dr. Sushmita, thank you so much for those kind words of introduction. I would like to also thank the management of Siksha Anusandhan and also the Institute of Dental Sciences for this wonderful opportunity. It's very heartening to see, should I say, a great amount of participation and interest to all the webinars that have been conducted by our dental school. My special thanks go out to Dr. Satyaranjan Mishra, who invited me, just called me one day and said, would you like to speak? I said, yeah, sure. I'd be happy to speak any day. Especially interacting with students and faculty from other institutes is a wonderful opportunity. I know the pandemic has been, it's a terrible time with the pandemic, but if there was a positive or there's still a silver lining, one thing I've been seeing with the pandemic is we all somehow seem to communicate better. We all get to know each other. We at least know where we're all working. Faces that we've never seen before, we're actually seeing now. So that's absolutely the silver lining to this pandemic, I guess. I think what I do today is we actually had a discussion on what has to be spoken. Then we said, okay, let's look at orofacial pain. It's an absolutely vast topic. As we go through the slides, we'll also see that orofacial pain is more like a subspecialty now. So probably not an hour, it will probably take a 3-year course henceforth. So I try doing my best my thoughts on orofacial pain, especially with regard to diagnosis and management. Before I actually begin, let me try sharing the slides with you with Dr. Shushmita or Dr. Satyaranjan can let me know if you can see this.
Yes, sir.
Okay, hope that is visible.
Yes, sir. Yes, sir. It's coming.
That's right. One more nod. Yes, you can see this slide.
Yes, sir. Warm greetings from Manipal Academy.
Great. And also, I'm audible.
Yes, sir.
Okay, great. So, without further ado, let's begin this 30, 40 odd minute interaction with all of you. I understand from Dr. Satyaranjan Mishra that this is a wide audience, so we have various specialties, PGs, I guess students too. I'm just going to slightly look at a different perspective of this topic today of orofacial pain. Although I call it orofacial pain diagnosis and management, I want to look at, so I want to take a slightly step back and actually look at where have we all forgotten to be very subjective. Somehow over the past decade, we've all been trained to be very objective with orofacial pain. And I think that's the biggest pitfall. We've forgotten to be very subjective. I think it's time we begin to get very subjective. The way we discuss with patients and communication, I think, is an absolutely important step. So I want to look at very basic clinical interaction with patients, read and understand about orofacial pain, and I guess that could happen in various other fora. But for today, I want to take a look at orofacial pain from a totally different perspective. Let's understand what's the magnitude of the problem first. How big is this problem? It said almost like 35 million dental office visits. And these are people who chose to visit somebody. So they're also people who are just sitting at home and also suffering from pain, but 35 million visits a year. Look at the next statement that was in the JAPI, the Journal of Association of Physicians of India. It is a quarter of the population experienced orofacial pain in the last 6 months. So pain is there, pain is there. Prevalence 40%, and like we all over time understood as we read books, as we went through, we understand that somehow women tend to suffer more. Could be autoimmune disorders, could be psychosomatic illnesses, could be even orofacial pain. Women tend to have more prevalence, should I say, more represented orofacial pain. And the next statement is absolutely very interesting. Orofacial pain is common in young adults, but look at the next statement. It says, least in persons over 60 years of age. It's very surprising to know that. But my understanding of that statement is probably as you suffer longer, you get used to pain. Or in this case, you just get sensitized. You understand how to deal with it. You probably have more social support around you. So the younger generation tend not to don't have better capabilities to deal with pain. But as patients age, they begin to understand pain. So the prevalence, when they say that it's common in young adults, but least in persons, I understand maybe it's there, but they're not probably presenting to you with the pain. They probably have other complaints to tell you, but not pain really. And especially pain per se could be very, very prevalent. But when it comes to orofacial pain, this has a huge bearing because it has both biological, emotional, and psychological components. But the biggest challenge for us, oral physicians, is because the orofacial region has an important role in everyday life activities. So be eating, drinking, talking, and that's where we have to engage with patients. And just to let you know, it was so severe that in 2013 and 14, the International Association for the Study of Pain called it the Global Year Against Orofacial Pain. So this problem is very, very much prevalent. This is not a typical theory class. So I'm not going to give you definitions, but let me try to understand these definitions a little more better because it will give us that subjective that I started off this interaction with you saying, where have we lost this connect with patients? So if you look at the definition by IASP, this is that very popular definition, right? The unpleasant sensory, emotional experience. Could be an actual or a potential tissue damage. We'll go back to Bell's definition. Weldon Bell, 2017, the Bell, classic, very famous person. Look at his addition to ISP's definition. He said the subject's conscious perception. That is, how do we feel about pain? The perception of pain is what Weldon Bell talks about, and I think that's where we really lost that connect. This definition by Hamlin is more of very theoretical and academic and probably Viva interest, because I remember even during my Vivas in the early 2000, I should say 2001, I had this examiner asking me what is face and what is orofacial pain. So that definition probably holds good. So it gives you that anatomic definition, orbitomeatal line. So don't worry too much about this, because we know pain is now not really restricted to one specific area, but could be referred, could have multiple sources where the patient can multiple places where the patient can perceive pain. So I don't think that definition you really even need to know, maybe just to probably keep an examiner happy. Now ISP did a great job by re-looking at its old definition, or the classical definition that I mentioned about sensory, emotional, and potential actual tissue damage, and then they came up with this very wonderful definition that gives it a little more broader perspective of pain. So they say it is perceived in the face oral cavity, but can be caused by diseases, disorders of either regional or from a very far off distant source. So they give it a more broader perspective of orofacial pain. And the AOP, this is that definition that will remind us time and again that we need multidisciplinary approach, and it's a huge subject. AOP gently pushed in words, calling it a field of orofacial pain. Exactly where when I began my interaction with you, saying it's a subspecialty on its own. So we look at the various things AOP discusses. It says prevention, evaluation, diagnosis. It's almost like going through the definition of oral medicine once. Okay. The other interesting concept I found when I read this multiple times is, if you look down below, it says syndromes in which pain constitutes the primary problem, and they also add TMJ disorder pain. So TMJ disorders, neuropathic pains, headache, they now start looking at all of these like almost like syndromes, where pain can be a common thing. So when you look at these definitions, don't worry too much about how much you can remember probably for an exam, but it's more important to understand what are they actually trying to convey. So this gives you that broader perspective that orofacial pain is really a big specialty on its own. And what are the orofacial pain disorders? This again from the American Academy of Orofacial Pain. They gave a huge list of conditions that can be categorized under orofacial pain, right from TMJ, cervicomusculoskeletal pain. What's very interesting is, yeah, sleep probably crept in a little earlier, maybe a decade ago, sleep disorders. But look at orofacial dystonias too. Orofacial dystonias, like, involuntary contractions, facial movements, involuntary movements. All these also now are actually under the ambit of orofacial pain disorder, apart from, of course, the systemic disorder. Just to give you a perspective that multiple conditions are now categorized under orofacial pain. So hence again, emphasizing the fact that you need a multidisciplinary approach. It's not just one person, an oral physician sitting in the clinic is probably not just enough to manage orofacial pain. Now, diagnosis of orofacial pain following the introductory. I like to take you back in time, because I always believe, especially being in oral medicine, and always my passion has been to interact with patients, because patients will tell you a lot of stories, and that's when most of the diagnosis happens. So look at that. Nobody wants to go back in time, but did we lose our sense of sympathy when we lost the shared experience of pain? So I told you I'm going to take you to a different, this interaction is going to be slightly a different mode. I'm not going to take you to the typical orofacial pain class. So let me say that, have you lost the shared experience of pain? If you remember your first fall, if you remember when you scraped your knees, you always wanted to go share with somebody, right? Even as a small kid, I also now see my 6-year-old son with every single fall, probably even potential fall, he'll come back and say, look here, this is what happened. Unless you say, oh, is it okay, what happened to you? Unless you show that sympathy, he's not going to tell you exactly what happened. So I think we need to go back, step back in time, understand that history taking is very, very, very important. And just to tell you how important it is, I'm going to share some more slides with you now. Do you remember, I mean, I knew we had a family physician at least 2 decades ago. But over time, I really don't know, do I have a family physician? Maybe in small towns, yes. But we really don't have the typical family physician these days. The person who knew everything. He had the medicine for cough, he had the medicine for fever, he had a medicine for pain. And all these were generally very generic. All my senior colleagues and senior teachers would remember times when cough syrups were poured in those colored liquids into bottles that helped us. Some pills that the doctor gave you and it just worked like magic. So we've not, certainly those days of family physicians have gone. And I don't know if it's okay to say, but the Meckel's pain questionnaire, many would disagree. I have very senior faculty listening in to me today. But I somehow feel we have moved, the Meckel's pain questionnaire literally killed pain. You have to tell, patient has to tell you, this is throbbing pain, this is pricking kind of pain, this is gnawing pain. So we are forcing him to describe pain in only those specific words. And I somehow believe we've all stopped listening to our patients. And look at Charaka, he said, when I enter the patient's house, the speech, mind, intellect, senses are entirely devoted to no other thought than that of being helpful to the patient and things concerning only to him. It's nobody else around. You have to only listen to the patient at that point of time. And pain management happens right there, listening only to the patient and nobody else. If you look back at old literature, it's very interesting to note how pain was described earlier. It was never pain, Meckel's questionnaire, it was never the visual analog scale, it's none of those. They were just asked to describe. And the descriptions were pain is a monster, an intruder, it's like a knife that cuts, a dog that bites, or a fire that burns. And when this talk happened, it actually cemented or rather made the physician and the patient much more closer. And if you notice, we always share our suffering with loved ones. So you should ensure you have the kind of closeness with patients. In fact, I also feel very disheartened sometimes to see my own postgraduate students sharing those so-called pain patients with other PGs. Oh, I'm not posted here today. Can you have a look at him? It's okay. But if you miss an appointment with that patient who's suffering from pain, that connect is gone. It's never okay to share your patient that he has confided or he or she has confided in you the type of pain, because you alone, when you treat the patient, will understand how beneficial your treatment was. So never don't even attempt to share your patient, especially when you begin to interact with the patient, take his history, you will ensure that you treat him for as long as he wants to be treated with you. So that kind of intimacy is missing. And so that's one thing that we all have to bear in mind, especially the young postgraduate students. Please ensure that you bond with the patient so that they describe the pain in exactly these terms that you understand. A very interesting, very, very interesting thing that I read when I was looking at literature quite some time ago. There's this textbook, I mean, though it's not orofacial pain, but actually describes pain very well. I'm sorry about a lot of material on the slide, but look at that, those words. There's a shift from encouraging the active and verbose pain. If you notice, some patients will walk in and just want to keep talking to you. That you have to encourage that verbose, it's a lot of talk. Nowadays, all this is not encouraged. You love people who are silent. Why is he talking so much? Oh, he's boring, he's bugging me. I hear all that from students. This patient talks quite a bit. I need to finish my quota. It's time up. I have only 45 minutes. I need to finish. We need to encourage patients to talk. Look at how this, there's a popular clinical text on disease of the bladder and prostate gland. Essentially, they're just talking about a man with kidney stones. That's all, just kidney stones, okay? They're saying the jolting of the carriage is unsupportable to him. Means if he's probably going in a carriage, he just can't bear that pain. As the evil increased, micturition becomes more and more frequent and distressing. Pain following the act, that is micturition, is very severe. Patients writhe with their body, so it's literally grinding teeth in agony and moving his body. That's the description. The same book, look at about 20, 30, 40 years from when it was published in 1938, another edition of the book, the same authors. This time, it's like we all know, we all love this, right? The jolting of the carriage increases symptoms. As the stone increases in size, micturition becomes frequent and distressing. Pain or uneasiness at the end of the penis becomes more constant and severe. This is how we've all been taught to write in our case histories, and yes, this is the way it is now. But you don't really understand what's it doing to his quality of life. The one on top is actually describing, and when you manage pain, this is what you're looking at. Have you improved the quality of life? Can he now go in a carriage? Will he not grind his teeth in agony? That is what you're looking at. Not at, okay, now it's constant, it's become very severe, oh, not severe, not mild, moderate. We got into that kind of a focus. Somehow we need to move away a little more from being very, very objective. We need to get into a little more subjective, and medicine is very subjective. So we need to get to that nice, comfortable place where medicine starts to become more subjective than objective. And these are some things to again emphasize all that I said. Look how things were described earlier. Pain is like a demand from Her Majesty's Inspector of Taxes. So it means it keeps coming very frequently. The Inspector of Taxes would probably the Majesty, the King, or the Queen in this case. The Inspector of Taxes is going to come to you and say, look here, you need to pay me. And the phantom limb pain, look at this, champagne bubbles and blisters. And of course, children who can talk about, I feel like mosquitoes are poking around me. But no, now you're not allowed to say all this, right? You're only allowed to say pricking pain. This pain is very mean to me. Can you say mean now? You're not allowed to say mean in the case history sheet. But then, when you write somewhere, at least have it in your mind that this patient is calling the patient mean, or when he says a lot of banging I hear, I have a banging headache, the next time you meet him in a week or 10 days or whatever you meet him, when you ask him this question, hey, you told me you had a lot of banging, what's happened to that? You say, oh, yes, doctor, that's improved. Rather than saying, you told me it was a periodic, and those kind of words that I wouldn't remember, the patient wouldn't remember. So it's best to go back to these kind of very narrative write-ups. Okay, so this is just one line to think about, and then we can go in further. We'll get on. So now what's happening, the emotional and aesthetic pinning of clinical language has continued, okay? And then we're moving from the subjective experience towards so wherever the subjective experience, we are really moving it right away. We do not want any more subjective. So, and the second thing is we've introduced these funny scales, the VAS, a line with no pain and the worst pain imaginable. So we move it to the end and say, tell me now, 0 or 10, or 3 or 4 or 5. Yes, it's nice to have those scales, but it's also good to know that you need to describe pain very subjectively. It really helps you when you manage your patient, not treat, manage patients. Okay. So now let's go back to our very objective lives. So now what we need to do is essentially describe pain as whether it's acute or chronic, and whether it's a primary pain, that is a pain right at the source, or some kind of from a different side. Is it heterotrophic? That's what you need to essentially do when you diagnose pain. It's as simple as that. You just have to say whether it's acute or chronic pain. Slightly over time, this acute, chronic, though we have these some kind of an understanding for various disorders, what is acute, what is chronic. Some people say more than 3 months is chronic pain, less than a month, less than 3 weeks is acute. So more than, I think, using descriptors like that, I think we should be able to say acute pain is usually whatever pain is there, it is in concordance with the tissue trauma. A lot of tissue injury, it means probably patient has it is acute pain. Whenever you remove this injury, whenever the injury resolutes, then the pain goes away. Okay, and very, very important to know about acute pain is especially what is the body doing, what's the autonomic nervous system doing with the pain impulse. So whenever you see some kind of a protective mechanism, for example, you must have actually run a couple of times or played a sport like say badminton or tennis, and suddenly you have your calf muscle in spasm, you're eating something hard, suddenly the muscle goes into a spasm. You have that typical splinting of muscle, which is very popularly called a protective co-contraction. So these kind of reflexes happen only with acute pain. That's very, very clear and clear cut. The issue most of the time is chronic pain. Acute pain is absolutely beneficial. You need to have pain because that's going to, we all know, it will prevent the body from probably getting to further damage. So you need acute pain. It's very, very beneficial. To me, the most of the problems occur with patients with chronic pain. So whenever there's these, you cannot understand, or there's low level of pathology, there's absolutely nothing, but this patient is still suffering from pain. Then you say now the patient is in some kind of a phase of chronic pain. There's some kind of central sensitization that's happening. And most of the times, the aggravating factors are not really related to the cause. They're not in that site. It's somewhere else. Something else happens and patient would tell you I have pain on my face. And always remember also that there is a kind of a chronic phase, but patients would have those periods of acute exacerbations. Majority of the patients, I should say almost everybody at least I've seen with chronic pain, have absolutely different mood changes. They're irritable. They don't talk to people much. They also tell you that their social life is disturbed. They don't go to work often. They have disturbed sleep. So these kind of changes that take place are all related to chronic pain. So it's important to understand based on the patient telling you, doctor, I'm not able to sleep from so many months. I feel very irritable. You're already dragged. You should be driven towards the fact that, okay, now it's probably the patient is in a chronic phase of pain. It's not really only duration. Okay. Some more concepts on site and source of pain. So when the patient feels pain, wherever the site of pain is, then you'll say it's very, very simple. This site of pain is very simple. Just say, can you please tell me where exactly? They'll generally vaguely point out the side of the face. Get into some more, first start off with probably a diagnostic interview can start off with a very open-ended question. Can you tell me where is the pain? Why are you here? What is troubling you? Those are very open-ended questions. And when you get to know that the patient actually describing some things, you can now get to a closed-ended question. I understand, but now can you please point out where exactly do you have pain? And that kind of pointing out will show you the site of pain. Okay. And then, of course, when you say source of pain, it's that area from the body wherever this trauma or injury or nociceptive stimulus is, or the input is, that's where originate is referred to as the source of pain. So when the site and the source of pain is pointing out there, that's my tooth. Because if my sinus is where it's paining, it's hurting me. So when you have that together, then you call it a primary pain. Okay, how about heterotrophic pain? So these are kind of, there's various types of, we could have a central, projected, and a referral pain. But main point you should understand here is, whether the patient has pain, it need not be, he may show you pain there, he may show you pain around the neck. In heterotrophic pain, it is never, the site and source are not the same. And why is it so important? Is because, look at that last line. I should say the guarding principle or the ruling principle here is that is for any kind of treatment or management that you offer, it will only be successful if you can manage the source of pain and never the site. Okay, so finding out that source of pain is what takes a lot of diagnostic skills, and maybe that interaction with the patient will help you understand the source of pain. Okay, this is a typical history that we need to record. These pain diagrams that you have, or rather should I say line diagrams or diagrammatic representations, are absolutely essential when you see patients with orofacial pain. These are sites patient can point out. You can actually encourage the patient to draw sites that are painful, and that will help you manage pain better. So apart from the typical demographic data, it's good to get the medical status and look at this, the pain complaint marked on a pre-prepared drawing. So on these drawings, you'll ask the patient to point out its pain. Of course, you get the pain onset, how often, when did it actually start. It gives you more in terms of the chronicity of the pain. And then, of course, aggravating relieving factors. We are all very familiar with this, right? What's more important is we all miss out is the last few points on pain in other body regions. Yes, we are all orofacial physicians, but it's also important to understand pain. We just understood about heterotrophic pain. So it's also important to understand it's not in the head and neck, but generally where else does the patient have pain. And does it affect your quality of life? And this is what you need to target when you manage pain. And this is a scale. Apart from just getting a visual analog on the severity of the pain, you also need to check, has your management improved the patient's quality of life? Simple things like, did you sleep well now? And does the pain wake you up from sleep or disturb sleep? You're thinking to check. So I was really surprised when I was again going through literature. This is for maybe postgraduate students who I hear some examiners asking, where do you get this big list of what to ask? There's Rice's classic analysis of pain in 1936. So right in 1936, these 11 essential questions in pain history. So they were there right then. So right from then, these typical onset, frequency, duration, all that was present. That's just for academic interest. Okay, these are our typical objective methods of assessing pain. You could use pain scales, you could use questionnaires. And of course, the other segment on the right-hand side that you see is more to do with chronic pain, where you're essentially checking for mood disorders, depression index, so the psychological assessment would happen with the other scales. However, one very, very important here, you should all know is whenever you plan to use these kind of psychological batteries, it's always good to refer the patient or at least have the psychologist with you, because maybe it's as simple as marking a few things. Patient is not able to eat well, he's feeling very depressed, he's not able to perform his daily activities. But the interpretation needs to be done by a psychologist. So let's not cross into their domain. Always nice to refer, or at least get the psychologist to look at these ratings. We could probably stick to just the verbal rating scales, the McGill pain questionnaire. But when it comes to psychological assessment, please use help. Okay, these are various scales. So in summary, when you look at the clinical evaluation, you look at the very important look at vital signs, do a good eye evaluation, ear evaluation. Again, if you're in doubt, no harm sending the patient out for evaluation by a medical physician, especially when you have to do balance, coordination, and clinical evaluation. Though we've been taught, it's always nice to get a neurologist help, especially when you're dealing with patients who've been suffering from pain for a lot of time. And of course, you could do a good muscle, you should rather do a good muscle examination for tenderness, trigger points, pain referrals. They have also something called trigger points, just areas of, you palpate a muscle and it's one specific area, it's very tender. You also have something called taut bands. These are popularly referred to as knots. The physical therapists would probably be in a better position to explain taut bands, but when you actually palpate the length of the muscle, you will find areas that are knotted. They're slightly more elevated areas, and those are which are tender. So those are called taut bands. Trigger points are just specific tender areas. Some people also like to use trigger sites. And then you can check the mandibular movement. You get the mouth opening measurements. Look for, I guess, TMJ was done in the previous webinar, but good habit to check the patient has deviation, deflection, check for pain, and then evaluate the TMJ. Also, do not forget to check oral structures. What's it all trying to tell you? It's not very comprehensive evaluation. It is not your typical case history record that you just pick one line and say patient has pain and myositis, whatever we diagnose, but it's important to maintain a separate case sheet, ensure you do a good clinical evaluation, ensure all these questions are asked. Okay, this is a very good summary table. I took this from the University College of London, UCL. It gives a good differential diagnosis for orofacial pain. Some of them are very, as oral medicine physicians, we are all very aware of many of these. But it's very interesting to note some findings, and this has been populated with various literature review. That's what the author claims. And when I had a look at it, I was really surprised to see multiple areas. For example, when you look at, we are sure about reversible pulpitis, irreversible, but look at periapical periodontitis, the typical apical periodontitis. And then there is pain with paroxysmal. Okay. In acute pericornitis, again, when we look at acute pericornitis, the pain is continuous in nature. The exacerbating factors are when you bite, and the referred area for acute pericornitis is ear. Okay. And then bone pathologies like dry socket. The pain is very sharp. It's a deep-seated kind of pain. It's very deep-seated. The pain is moderate to severe. And again, unilateral kind of a pain. So reversible pulpitis, reversible apical periodontitis, acute pericornitis, should I say dry socket, all these pain associated with are very, very regional, localized, and unilateral in nature. And this actually can share PPT with the organizers, and you can actually have a look at this. Let's look at the maxillary sinusitis. The pain is very dull, aching, and boring. Now again, if it's an acute kind of maxillary sinusitis, I've seen patients who really suffer from a lot of pain, and mostly they come with complaint with pain in the tooth. But if you actually palpate the sinuses, they're extremely tender. But as it becomes chronic maxillary sinusitis, the pain gets very dull, very aching, and very continuous, boring kind of pain. And a good way to diagnose this is asking the patient to sit on the chair, bend his head down, tilt his head down for close to about maybe half a minute, 45 seconds, and then the patient will tell you it's starting to get a little more heavier on my maxillary sinus. Also, the other thing you can do is use the back end of an instrument, like a mouth mirror or probe, place it between the occlusal aspects of teeth, ask the patient to gently bite. The kind of an occlusal load will actually, because of the close proximity of the tooth to the maxillary sinus, will actually cause pain in the sinus region. Okay. Also look for, now this again, very things you have to look for is, when you look at the patient, major of these people with maxillary sinusitis, though bacterial is pretty common, they also suffer from allergic rhinitis. So you're looking for some kind of very, should I say, very eye-catching features like the allergic shyness. You have a kind of a blackish discoloration around the eye. Then you have something called, these people have something called a horizontal salute. Yeah, the typical upward rubbing of the nose. So you'll see a horizontal crease on the tip of the nose. So these are some things you'll have to look for. And also look at the palate. You might see some erythematous petechiae on the palate. This will tell you that frequent allergic rhinitis has actually caused them to sneeze very, very frequently. And then if you have also this unilateral pain, the sinus being very tender, it's definitely maxillary sinusitis. Okay. Then pain associated with silolith, obstructed salivary glands. Majority of them would be submandibular, like we all know. A very typical burning kind of a pain, especially when the salivary gland, the duct becomes full. And we all know it's generally the pain increases on eating food. The pain again here is very paroxysmal, especially on eating food. And of course, the pain goes away when the patient stops to eat. EMD pain can vary from being very dull, throbbing, to very, very sharp kind of pain. Okay. And the referral patterns are mainly to the ears, head, and neck. Burning mouth syndrome. You have a lot of the patients complaining of this atypical kind of a burning sensation in the mouth. And of course, some amount of burning also on the tongue, glossopyrosis, glossodynia, pain in the tongue, burning in the tongue. All these are components of the burning mouth syndrome. The typical descriptions are it's burning, there's tingling. Some people also complain a very itchy sensation on the palate, and the pain could either be continuous or paroxysmal. Okay, postoperative neuralgia, typical of once the virus becomes dormant and reactivated. So when localized to the site of the herpes zoster infection, intral are very, very common, but of course, extral sites around the pinna of the ear, aware of that. The pain is burning, tingling, and shooting kind of pains, sharp. These are typical adjectives that we need to use when we follow Michael's pain questionnaire. Right. Okay. The trigeminal neuropathic pain, it could either be local or it could be really widespread, especially to that specific neural anatomy, especially around the course of the nerve. And look at every single time. So it's not really the textbook variety of if it's trigeminal neuralgia, it is this kind of pain. It's not really. The descriptors can actually keep varying every time for pain. It's important to interact with the patient multiple times to understand what kind of the pain description he's using. All of them may not be very diagnostic, these terms that I use. Glossopharyngeal neuralgia is again very sharp, shooting, and stabbing kind of pain. And important here is swallowing, coughing will actually trigger the neuralgic kind of pain. Okay. Okay. Cluster headaches, they're unilateral, and the common site would be temple and the periorbital region. And these are they happen so frequently and rapidly. You actually patients will complain of almost like 5-6 attacks in a day. They're very, very frequent and they last very long. Until once it goes away, it starts all over again. Cluster headaches have to be recognized. For these, the triggers, especially for these vascular kind of headaches, are smoking, alcohol, altitude. These again, majority of them actually complain of the things like mountain sickness. People who have traveled to high altitudes, suddenly going from lower mountain ranges to the higher, have these cluster headaches. Okay. And then paroxysmal hemicrania. Again, these are all attacks that can happen multiple times. It will not be very common to see them in a clinical setting. Let's go right down that list to migraine. So in migraine, the pain is unilateral. It's a throbbing kind of pain, and it's paroxysmal in nature. And look at migraine headache. Migraine, the triggers are stress, food, exercise, alcohol, estrogen, and some amount of pressure changes. That's about. Now, what are the major times when we cannot diagnose, including myself a couple of times, you tend to categorize the patient as patient having psychological pain. This patient cannot be treated. It's a psychological pain condition. Please understand that these patients, no matter what medication they take, would have a constant discomfort. They will not be able to describe where is it located, how the pain. It could vary from day one, could be a throbbing kind of pain. The next day you talk to them, it could be a pricking kind of pain. So you will see descriptors of pain change very frequently. The pain could vary from one site, it could be multiple sites, could change every single day. And no matter what, the pain can get worsened. So when you feel any of these symptoms like this exist, and there's no disorder, you can actually say this is what is causing pain, then you're probably allowed to call it a psychologically or psychogenic pain disorder. One important clue for most postgraduate students here are majority of these patients would carry nice thick prescriptions that have, would carry a lot of, you'll have patients coming to you with multiple prescriptions, thick wide of prescriptions with different medications. Again, this good time to probably use help of a psychologist when you're dealing with these kind of patients. This is a good chart again to describe what chronic. Once I share this, directly with the organizers, mainly useful for the postgraduate students. We probably have to look at that. Now, how do you manage orofacial pain? I'd like you to look at the people who watch. See if we can run this. Right. Okay. I don't think I'll be able to run this. Anyway, it's a video, it's an interesting video from the Premier League, people who watch football. You have this football actually falling down and then mimicking that he has pain. He laughs at everybody, and the camera actually captures him laughing at the referee. He is acting like he has pain, but we all should know that pain is really for real. You cannot say that patient is just coming here. Pain is very, very real, and we have to manage that. You have to ensure that whenever you begin to the typical calling it a orofacial pain clinic, good to always team up with other people, the ENT people, the neurologists, the oncologists, definitely a physical therapist. I, for one, believe a lot on physical therapy, and it really helps. And always ensure that you also have your team members from other dental specialties. It's just not about I'm oral medicine, so I want to stick to my branch, and orofacial pain is my domain. It's not like that. Please use help, because you will need people to correct a lot of other dental anomalies to help patients relief of pain. Okay. The main things are, what are your goals? You will ensure that you minimize pain, the burning sensation has to reduce. So on your case sheet, especially when you're looking at mucogingival pains, you will ensure that you have all these side headings. You'll say, okay, it's mucogingival pain, so I want to look at pain, I will reduce burning sensation. I need to ensure that there's no more inflammation there. I should somehow improve the salivation, and then if required, immunomodulate. This especially is important when you give acute stomatitis. Your topical anesthetic agents really help. Topical anti-inflammatory agents. A very popular one is benzidamine hydrochloride chloride. It's a good anti-inflammatory agent that comes as a mouthwash that can be used. You could give topical NSAIDs. You could antibacterial, antiseptic mouth disease, salivary stimulants, and if it's herpetic agents, you use antivirals. And of course, if it's to do with any autoimmune condition or immune-related condition, autoimmune-mediated condition, like inflammation, you will use steroids, especially the erosive form that's causing mucosa. The pulpal tooth pain is very, very easy. It's very definitive. You need to treat that tooth in question with either NSAIDs and definitive treatment like root canal treatment, and then it's easy to manage these patients. Sinus-related pain, steam inhalation really helps. You could use mucolytics. Antihistamines, like I mentioned, if you're looking at patients with history of rhinitis, then go ahead and prescribe antihistamines and use antibiotics. And a simple thing like amoxicillin really helps for bacterial sinusitis. Okay, this is taken from my book for neuralgia. For trigeminal neuralgia, I think we all are aware carbamazepine really does wonders. So actually, you don't need to go beyond carbamazepine. Of course, there's a lot of push. People also talk about oxycarbamazepine because it has lesser side effects. Of course, that even works. About 300 milligrams, taken twice a day. To work, and most of these you would not exceed over 1200 milligrams a day. That will really help. Majority of my colleagues, myself, I also found good relief when you add gabapentin with carbamazepine, because that is a combination that really works. You would not normally begin to use, you would probably see many refractory cases, especially medical management. Though we've also added baclofen sometimes for refractory cases. It's just a personal thought. I normally, after the first line of treatment phase, if the patients are refractory, I think you should just be very open to the idea of looking at an MRI, getting consult from a neurologist, rather than trying out the textbook prescription of Lamotrigine. I don't think we should actually, again, it's a very personal thought, we shouldn't be going into other domains, I feel, because if you need, you're ultimately treating a patient. There's absolutely no harm in getting advice from a neurologist. So I think the first line of treatment is absolutely, definitely, I think we should treat the patients. Burning mouth syndrome. You get this capsaicin gel that really works well. We also had great results using ALA. It works. Apart from that, yes, amitriptyline can be prescribed. It's good. Majority of patients have lack of sleep, are very anxious. So alprazolam 0.2 mg bedtime dose. Though you can use a 0.25 mg BID, I would suggest maybe just a bedtime dose of alprazolam for a week. Slowly you can withdraw the drug. Okay. TMDs, majority of the orofacial pain that we see are actually related to, sorry, Dr. Satyaranjan, maybe another 5-10 minutes. Is that okay?
Yes, sir.
Yeah. Thank you so much. So it's 5-10 minutes and we can wind up. Majority of the TMDs also cause orofacial pain. I think it's very, very important not to just focus on the pain the patient presents, but do a good evaluation of their dentures, look at faulty restorations. So this is where I was telling you, it will really help to refer your patients out. Yes, it's fine. We could take a good, nice history, probably even diagnosing these are all faulty. I think day one, when you actually see a patient, it's a good habit to refer out patients to an orthodontist, to a prosthodontist, to a conservative dentist to look at other things that cause TMDs. Once you know all that is being taken care of, all the other issues that are causing TMD pain, then I think we can call back the patient to the oral medicine clinic and begin to treat the patient. How do you treat TMD related pain? I think the first thing to do is to let the patient know that soft diet is very important. And if you recollect way back when I began this interaction, I just said pain is beneficial, and this is exactly what we do with when you treat TMD pain. Never kill the pain. We do not want the patient to be pain free. Not that we don't want him to be pain free, but the fact is when you're treating the patient, you do not, especially TMDs, you do not want them a couple of muscle laxants, a couple of painkillers. The patient will suddenly have a lot of pain relief, and then he'll overuse the muscle. In fact, you had a spasm and the muscle sprinting by the body to prevent all this damage. But you overriding all this and prescribing analgesics and muscle laxants will actually motivate the patient to use his muscles more. That we don't want. So you will get to a point where you actually just kind of manage the pain, but you don't want to feel the pain. And then you give advice of do not excessively mouth open, don't yawn. And forks and spoons are much advisable rather than using fingers to eat. And of course, you could use some short term, and I say it's short term again, remember, not too long. What you can do is, massage really helps. The vapor coolant spray, we all heard of the fluoromethane spray, described in many textbooks. So what the physical therapists do is not use that, but alternate between. I just go to that. I think there's one slide on it. But you can alternate between a hot pack and a cold pack. If you do that, it will really help. Again, this is just for you all to know because especially postgraduate students, I've already interacted with my PGs. Have you given physiotherapy? Have you told a patient to use a moist state fermentation? Yes, sir. How long and how many times? Nobody really knows. So what we really need to do is whatever heat you're using, it should be moist. Generally, a good idea is to have a wet towel. Microwave if you cannot, at least put into a pressure cooker or even iron it. But it needs to be moist, it needs to be warm. It should be at least 40-50 degrees. It should be really a typical moderate warm. It can't be lukewarm. It needs to be warm. And then 20 minutes. So the application time is at least to keep it for 20 minutes. And also there's this great use of cryotherapy, though we can't, there's a good article on cryotherapy used for TMD, but what can be actually done is to simply, I've also seen these, a lot of, should I say, my own postgraduates or from other departments, gloves, hand gloves, you put some ice cubes into it, wrap it nicely, taste again, that's not okay. You're supposed to wrap this thing into again a towel, use a towel to wrap all this in, and then place it on the site of pain, and at least place it for 10 minutes. This should at least be placed for 10 minutes. So that's important, and you can actually alternate between hot and cold. Okay. And then they are wonderful. This I would suggest look up. There are multiple sources where you can learn these isokinetic exercises, and these really help the patient from relief of pain, especially chronic TMDs with pain. One of them is these goldfish exercises. So I urge the PGs to look up internet for goldfish exercises. I have some things there. This is typically the good, and these have to be done. Please understand, need to be done very repetitively and multiple times in a day. And a good physical therapist will teach you all these exercises. So that's the importance of having a physical therapist on the team, and it really works. Okay. So there are multiple goldfish exercises. You can all go through that. Okay. I think we'll not go through it. And of course, a lot of, again, literature shown posture will actually cause TMD pains, the orofacial pain. So encouraging patients to do chin tucks. So hold for 2-3 seconds and repeat this 10 times. So the repetitions are important. The duration of these are very important. This is not doing it once. Okay. And in our clinics, at least, we had great success using shortwave diathermy for TMJ-related pain. And of course, even the therapeutic ultrasound machine that we use in the clinic, we found good results using therapeutic ultrasound for managing TMJ pain. The other things that you can also do, dry needling found some interest and excitement 5-10 years ago. I don't see enough written about it, but of course, TENS and MENS people use occlusal stents. A lot of work being done on occlusal stents for TMDs. So actually have a look at all that. That's all. I guess as I was mentioning, it's really pretty long. It's a subspecialty on its own. So I was just trying to give a different perspective to how you should actually look at patients. If I've probably driven the whole point that if you interact, especially with postgraduate students, please get a little more subjective. I understand it's not really encouraged in a clinical setting, but at least in your mind, you should say patient number 1, Mr. So-and-so, is describing to me that every time I bend, I find a creaking kind of a noise, or whatever the pain they describe, the kind of, they describe that. Those descriptors should be in your head, and ensure that you see your patient. Do not refer the patient to another PG. You will have to follow up your patient every single time. Dr. Satyaranjan has my email ID, so if you read something, please ask him, and then you can always interact. If there's something you want to know, I'd be more than happy to share. So I'll wind up this talk by just saying that the good patient treats the disease, the great physician treats the patient who has the disease. Thank you all so much for the patient listening. I'll be happy to take any questions from you. Thank you.
Thank you so much, sir, for an interesting and incredibly informative lecture. Shall we proceed with the question and answer session?
Yeah, sure, absolutely, yes, please.
So the first question is from Dr. Abhay. What exactly is subacute pain?
Okay, what exactly? Okay, it's a good question. So what mostly happens is most of the patients do not present with the typical findings of pain, but have all of the features that would mimic, should I say, the quality of life, the functions, the activities are all minimized and reduced. And I think that can be used as a good description for subacute pain.
Thank you, sir. The next question is from Dr. Satyaranjan Mishra, sir. How do we decide when to get a psychiatrist on board, and is there a time frame for it?
Okay, so I think there's a time frame as to when you should get somebody on board, but what we normally do is after you take a very good detailed history from the patient, majority of the times you identified the source of pain. I think if you can identify the source of pain, you know exactly where to refer the patient. Once the source of pain is not really, you cannot really, you do not know the source of pain. Multiple interactions with the patient will literally change goalposts every time, telling you the pain is, today it's a throbbing pain, tomorrow it's a stretching time pain. The location of pain is changing frequently. If you find these kind of indicators, patient is willing to talk to you for longer. I think that's the time when I honestly don't like to use the pain for this patient as a psychological end of thing, but I think that's the time when you probably want to get a psychiatrist on board. It may also be very prudent in interview number 1 to start off with using one of those depression scales. And when you know the scoring, you can do the scoring. But the interpretation, I think once you get a high score that this patient has probably depressed, I think that's when you should take consult from a psychologist. I would say psychologist first, not a psychiatrist.
Thank you, sir. The next question is from Dr. Rahul. How to differentiate psychological pain from typical orofacial pain?
Yeah, so exactly, I think the previous thing what I just mentioned was if you cannot probably identify the source, no matter how much you investigate, and then like I told you, the patient has various complaints every single time he meets you, I think that's when maybe then you'll probably have to label that probably the patient has a psychological related pain.
Thank you, sir. The next question is from Dr. Lingraj. Is there any difference in features to identify sinus pain and tooth pain?
Okay. So let me take it the other way around. So let me start off with the tooth pain itself. So I think a good oral examination, intraoral examination, if you look at the tooth, you find the tooth very sound, you don't have a carious lesion, you think the periodontal structures are very sound. There's absolutely nothing going wrong with the tooth. There's no cracked tooth. You take a radiograph, you see no periophyseal pathology if there was one. I think you can eliminate all that. So that's step number 1. So identify the dental cause first. Following which, you also look at the sinus. And like I told you, asking the patient to bend his head, tilt his head, look for any features of rhinitis, look for unilateral pain. I think if you can segregate these two as separate entities and say, okay, let me look at the tooth first, let me look at symptoms of the sinus, I think you'll be able to easily differentiate tooth-related and sinus-related pain.
Thank you, sir. The next question is from Dr. Abhay. How exactly the phantom pain has to be treated?
Okay, so there are a lot of, there have been many articles on management of phantom pain, because though there's no real reason why it's happening, the pain is for real. So I found enough literature also mentioning about use of even high-ended analgesics. I've also seen patients using tramadol because basically want to kill pain. And then a lot of patients find great relief with reducing anxiety levels. So I think, especially I'm talking only of literature now. So anti-anxiety medications with pain medication has shown to have some benefit with phantom pain.
Thank you, sir. Another question is from Dr. Abhay again. Administering an analgesic tablet before doing extraction or any minor surgical procedure, is it advised or not?
Okay, my wife is a maxillofacial surgeon. It depends. I mean, when I got my tooth removed, I took an analgesic about 30-40 minutes ago. So when the anesthesia wore off, I never had pain. But not many like it. And I also find a lot of literature again talking about the benefits and not so good benefits. They believe that some amount of, because the analgesics also have a mild anti-inflammatory action, right? So you want some inflammatory mediators to hasten the healing. So giving analgesics, I would say, would help the patient, but from a treatment perspective, maybe not to take it. Now again, let me tie both these together. So To argue this case, how many analgesics will you take? You just take one, right, before an extraction. So I would say it's okay to take an analgesic before an extraction. It's a different case scenario if you're taking multiple analgesics with, I mean, I know a lot of controversy on serratiopeptidase and everything else, but I would say one analgesic before an extraction has really not done any harm. Forget what literature says. But yes, you want the inflammatory mediators there. You don't want to kill them totally. So, but taking one analgesic, I think, is okay. Again, a personal perspective on this.
Thank you, sir. The next one is from Dr. Preeti. Why moist heat is used?
Again, one more time.
Why moist heat is used?
Yeah, absolutely. You just want to, so heat, what it does is to improve the circulation in that area. It is causing a lot of circulation to happen. So once there's more circulation in that area, wherever there's a muscle spasm, you're getting more blood. So more blood would mean more chemical mediators of inflammation there. So hence you're improving the healing in that segment. Apart from the contrary, where they say when you use a cold pack, the muscle spindles, the activity, you're reducing the muscle spindle activity in that area. So what is ideally done is you start off with you start with moist heat, improve the circulation, get some chemical mediators of inflammation. After 20 minutes, start off with a cycle of a cold pack. The cold compress will reduce the muscle spindle activity in that area. It's also believed to reduce conduction velocity of the peripheral nerves, and then hence less nociceptive transmission, hence lesser pain. So I would still say not just moist heat, but use an alternate between a moist and cold pack.
Thank you, sir. The next one is from Dr. Mrityunjay. Cognitive behavioral therapy, how and when to use?
Okay, so again, I honestly not, I haven't tried it myself except from very academic perspective. So I don't think it's, I think what I understand is to explain to the patient what he's suffering, or actually talking in terms of the patient to him about how to manage his pain. But I think I should not be delving into it. So I cannot answer this question because I not tried it myself.
Thank you, sir. The next one is from Dr. Jagannath. Do you recommend use of tricyclic antidepressant? If so, when?
One more time. I didn't get that.
Do you recommend use of tricyclic antidepressant? If yes, so when?
Okay, so tricyclic antidepressant, yes. Especially good relief, especially with burning mouth syndrome. So we use tricyclic TCA especially for burning mouth syndrome. Which I've used TCA.
Thank you, sir. The next one is from Kritika ma'am. Can VAS be really objective with so much natural variations in brain thresholds between the individuals? Is it more useful for comparison with baseline?
Yes, and yes. So I think I'm not a great fan of any of those scales, honestly. I totally agree with you. Though they're called the objective scales, they're not objective. But I think what you rightly mentioned is it's a good a baseline. For patient comes to me today, if he tells me I have if I have burn sensation on the VAS being 3 scale, it's a 0 to 10 scale. It's probably a good, for me, a good way to say how he's improving. But I'm not really a great fan of VAS. But I would say, like I just mentioned earlier, it's good to keep those the patient's adjectives in mind and then use that as a follow-up to him. But I'm very sure literature will not agree. I'm very sure when you want to publish something, let's say you can't say use some kind of adjectives, whatever you mentioned. So I would go with what you're saying. Yeah, they're not objective, though they're called, they're supposed to be objective, they're not objective. They're only good for in comparison for a follow-up.
Thank you, sir. The next one is from Dr. Shoaib Alam. In which case, hot packs and cold packs are different?
So, in especially chronic patient pain, especially with myositis, I'm not talking of muscle splinting. I'm not talking even of the earlier phase of muscle spasm. but in talking in terms of myositis, where you have reduced mouth opening, it has difficulty in opening, and it has been going on for quite some time, period of time. So I think alternating cold and hot pack in myositis patients will help.
Thank you, sir. The next one is from Dr.
Sorry, if I can clarify more on that. So if there's a muscle split, if there's a muscle split, I would suggest, because it's an acute phase, I would suggest start out with cold pack. Yeah, please.
Thank you, sir. The next one is from Dr. Nikita. Difference between styalgia and oral facial pain.
Tell me that again. I'm sorry, I couldn't get that.
Difference between styalgia and orofacial pain.
Styalgia, are you talking about the styloid ligament pain related to that?
Yes.
Yes. So, I'm not very clear of that question. If you can. Styalgia and orofacial pain. Difference, honestly, I haven't understood the question.
Thank you, sir.
Or maybe it takes me on that. I will be able to answer that better.
Thank you, sir. That was the last question of our session. Now I would request Dr. Smita Priyadarshini ma'am for vote of thanks.
A very good afternoon, sir. A very informative session, and you have indeed presented it very effortlessly. On this note, on behalf of the entire Department of Oral Medicine and Radiology, I would like to express my thanks to our esteemed founder president, University, Professor Manoranjan Nayak, for his unconditional support for all our activities. I sincerely thank Professor Ashok Kumar Mahapatra, Honorable Vice Chancellor, Shiksha Anusandhan University, for his unstinted support. I'm obliged to our driving force dean, Professor Dr. Neeta Mohanty ma'am, who had visualized this webinar series. It's a great pleasure to thank Dr. Ravikiran sir for being a part of this webinar and adorning on this important topic. I'm obliged to Dr. Shalnurai ma'am, Honorary General Secretary, IOMR, for her support, and gratefully acknowledge Team Agropene for their constant cooperation and support. I'm thankful to Dr. Satyanarayana Mishra for conceptualizing this mega series and getting all the upholders and experts to talk on this topic of such clinical importance and executing it so smoothly. Alone we can do so little, but together we can do so much. On this note, I thank all my colleagues, Dr. Shanad Bhuya, Dr. Rajat Mari, Dr. Abhishek Ranjan Pati, Dr. Basan Chaudhary, and all my postgraduate students, Dr. Rutsa, Dr. Supranita, Dr. Shusmita, Dr. Namrata, and the first year postgraduates, Purbasa and Dr. Anamika, who have been coordinating every minute detail. And last not the least, I thank all the participants for their constant support and participating so actively and taking use of this academic. With this note, I thank you everybody. Thank you so much, sir.
Thank you so much. Thank you. Thank you so much.
Thank you once again, sir.
Thank you so much, Dr. Satyaranjan. So that thing on, I still have that pending question on styalgia, so I'll take that. You can send it to me and I'll answer that sometime.
Yes, sir. So I think there are more queries which might come. I'll forward your email ID to them.
Sure.
Thank you again, sir, and thank you for everything.
Yeah, thank you so much. Take care. Take care, everybody.
Yeah.
Thank you so much.
Bye-bye. So we meet again on Thursday for the next webinar at 11 o'clock. Thank you, everyone.